kind of shave biopsy the papule.
Yeah.
Here we see what the actions relieve the dermis. We see these basaloid cells. It looks like a neoplasm.
Good.
We have a neoplasm.
Does it look benign or malignant to you at low power?
At low power, it is well circumscribed, but it looks malignant to me.
Okay, but architecturally.
Architecturally it looks benign.
Yeah,
but
it's very small.
Mm-hmm.
It's very well circumscribed. It's very symmetrical. So at least at low power, it looks benign. And there may be some things with a higher magnification may change our mind.
But it is well circumscribed. And here it's a little less, but still good, pretty rounded borders. Nothing infiltrating.
So what kind of differentiation do you think you were getting?
Sebaceous here. I thought I saw some pseudocytes.
Good, absolutely. So, two types of sebaceous cells.
Basaloid.
Yeah.
More basaloid.
Basophilic germinative type cells out here, and then you've got
more
the
mature.
Good, more mature types. So sometimes it looks benign at low power, and you get a higher magnification, you see other things that kind of change your mind. So what kind of changed your mind here? What are some things that made you think it was more likely malignant when you went to higher power?
It was quite disorganized. The nucleoli were also very prominent.
Yeah, it's got a lot of cytologic atypia.
There's some mitosis.
A lot of mitotic figures, and they're atypical, bizarre appearing mitotic figures. Okay, good.
So I thought this was sebaceous carcinoma.
Okay, good. And there's also necrosis en masse.
Right.
You see right there.
Which is always bad.
Now, is it possible that some part of the lesion actually might be benign and then another part might really be malignant?
Possibly, yes.
In this case, probably not. But sometimes when you get adnexal neoplasms that have been present for many years, they can gradually degenerate into cancer. So I don't think that happened here. I think this just looks pseudo benign at low power. And you go to higher magnification, saying, well, yeah, it looks benign at low power, but obviously it's not. So sometimes architecture can fool you. So that's an important teaching point in this case. So yeah, this is a sebaceous carcinoma. Probably didn't look like this, but this is an example of one. And basically, you know, the literature claims that these things may behave a little bit more aggressively than others, but that's not always the case. I've seen plenty of these behaviors kind of like a squamous cell or basal cell carcinoma. Sometimes they can metastasize, but how many people have you seen that have died from sebaceous carcinoma? I don't think I can remember anybody that's died. So it's pretty uncommon for it to really behave super aggressively. Well, it's in the literature they can. And one other teaching point about this is sometimes you can get intraepidermal pagetoid proliferation. So you see a little bit of an intraepidermal component of it right there. So it can kind of look like other intraepidermal pagetoid neoplasms. And it sometimes can be associated with uratory, not common. If you get one of these things that's away from the head and neck area, it's more likely to be associated with one of those. Yeah, exactly. Okay, very good.
Okay, so this was a punch biopsy. And extended down to the fat. There's an inflammatory infiltrate, which was mostly deep. Then I noted and extending right down into the fat. I noticed also that there was some, maybe some pigmentary changes, which aren't so obvious in this part.
What did you think that was?
I noted that there was some brown changes. I'm not seeing them right now. Sorry. And then there's some dark purple. Well, here I see kind of some inflammation, some blood vessels, some eccrine coils maybe.
Where did you think the main part of the pathology was located?
Deep.
Deep. How deep?
In the fat.
In the fat. Okay, right here. So, anything specific about this kind of change that you noticed?
Yeah, I thought it was ghost-like change. Like saponification.
Yeah, saponification. So you said there was some purplish material. What is this stuff right over here?
Calcium.
Calcium. So, and this is probably just maybe some lipofuscin pigment, or there might even be some possibly hemosiderin at the top. So what's the diagnosis?
Pancreatic paniculitis.
Good, pancreatic paniculitis. Now, is this really and truly an inflammatory paniculitis?
No, there isn't a lot of inflammation deep here.
But I mean, what's the pathophysiology of this process? Is it sort of the same thing as erythema nodosum and erythema induratum? And
No.
no, it's not. So what actually happens here?
I think there's more like reduction in vascular.
Well,
line.
how does the saponification occur? Do you remember the chemical reaction of saponification that you learned about in biochemistry years ago?
Not so much, no. But there's not. Well, it's enzymatic. I think.
Yeah, exactly. It's an enzymatic abnormality. It goes in and dissolves the fat, and then it undergoes calcium. Sort of ions precipitate with, or they react with the degenerated fat. You get calcium stearate, which is soap, and then that forms a foreign body, basically.
Okay.
And the body says, "Wow, there's soap sitting in the fat where it shouldn't be, and it causes all the secondary inflammation." And it also gets transepidermally eliminated a lot of times. So you get this drainage of these white, sort of chalky material that comes out of the skin. Sometimes it's oily, but a lot of times it's kind of chalky because it's calcified. And that's how this thing develops. So it's not really a true inflammatory paniculitis. So we call it pancreatic paniculitis, but it's really not actually a paniculitis in the same sense that some of the other paniculitis are. It's a different ballgame. So you have to look for pancreatitis or pancreatic carcinoma or some sort of abnormality whenever you see this. So this is specific. If you see this under the microscope, you got to go back and look to see why it's happening. Sometimes it's hard to find if they've got a small pancreatic carcinoma, for example. That Schmidt's triad, if you get lots of these lesions with arthritis and eosinophilia, you sort of get a worse prognosis with it, although if you have pancreatic cancer, you get a bad prognosis anyway, so that's not going to really make that much difference. Okay, very good.
Alright, have a punch biopsy, non-cacal skin. The action is in the dermis,
Okay.
so it's tough to see from here, but I thought these were like a spindle cell proliferation or neoplastic process.
Good. Now, what can you say based on this punch out of a sea of something that was bigger? Talk about breadth, symmetry, circumscription, and those kind of things.
No, I mean it's extending down. It's kind of eating up the fat.
Yeah, it's
taking
diffuse in what we've got. So in other words, it's very diffuse. It's not involving the papillary dermis, so that is spare. It's kind of a Gren zone, if you will. It's not involving the annexal structures, interestingly enough, but it does extend all the way down into the fat. And there's a very pattern that you noticed when it was involving the fat here.
It's kind of like haphazardly between the fat globules and then extending down.
Yeah, kind of dissecting around a lot of the fat lobules, sort of a honeycomb type pattern, like right there. Okay, so what was your differential diagnosis here?
So the spindle cells, I don't think they look like smooth muscle. I thought that this was probably fibroblasts or less likely nerve.
Okay. There are some cells in here, though, that sometimes go along with nerve.
Yeah, mast cells there.
Yeah, there's quite a few mast cells in here.
So yeah,
one right here, another one right here. There's a lot of them.
That helps my main differential, which was DFSP, looking at the way that it infiltrates and kind of going down.
Okay. Anything else?
Other.
Maybe not. I mean, if you're confident, you don't have to say anything else.
Yeah, that was.
So you would just go ahead and call it DFSP.
Sure, I'll be
Good,
confident.
excellent, very good. That's what I like to hear. A very confident diagnosis. So yeah. Okay, so this is DFSP. That's exactly right. And sometimes these can look like neural neoplasms. if you just had a shaved biopsy of this area right here, would you call that DFSP?
No.
No. That kind of looks like a neurofibroma. So it's one of the things when you're dealing with a soft tissue neoplasm, you have to realize that they can have multiphasic morphology. Some areas they can look more like a sarcoma, some areas they can look more like a neurofibroma. If you have something like this, so this is a biopsy that, thank goodness, allows us to evaluate the depth and breadth of the process, at least to some degree. So we know that it's very diffuse and goes all the way through the fat. So yeah, this would strongly favor DFSP. And then there's two types. There's an adult type and then there's a childhood type. And the childhood, you see on the buttock there, and a little kiddo, you know what that is actually called, the childhood type? For a bonus question?
Oh, the giant.
You're close. You got the giant part
There's a
right.
giant in there.
It's a funny name, and I don't know why they use it, but it's called giant cell fibroblastoma is the other name for this. We don't usually use the name. And is there anything specific you can look for here that might help you make the diagnosis? You can obviously do special stain. What stain would you do here?
34.
Yeah, CD34 is very strongly positive. What kind of chromosome abnormality did they get here?
Translocations, whole 1A1.
It's 17
Yeah.
22.
And platelet-derived growth factor beta. So you get collagen genes attached to a platelet-derived growth factor beta gene, and it ends up causing this thing to really proliferate dramatically. So that's why it is DFSP. Yeah, another slide or no. Yeah, so 1721. And they sometimes get a ring chromosome. That's more common in the adult form, but you can sometimes see it in kids too. So this is DFSP. This just happened to be in a kid. All right, very good. Very confident diagnosis. I like it. Good. Okay, who wants to do this one?
So we have a well circumscribed, it looks like subcutaneous mass, some neoplasm of some sort in the dermis.
Okay. And you think it's
Yeah.
benign or malignant?
From here, since it's well circumscribed, I would think it's benign.
Yeah, it sort of looks a little like that sebaceous lesion we had before, and fairly symmetrical, and you kind of draw a line around it. It's got multiple little nodular aggregations to it.
And you can
Okay.
see from here that there are a lot of lumens, so that's some sort of glandular
Good.
neoplasm.
Excellent. So it's epithelial, it's glandular, or we've got some areas in it that are differentiating towards some ductal differentiation here. Okay, get a higher magnification, and as opposed to the sebaceous lesion, we don't see a lot of atypia or mitotic figures or anything like that. What do you see here at this palette?
Looks like ducts.
A lot of little ducts here, and then what about the cells?
As far as the cytoplasm,
Yeah,
it's kind of pale looking.
good. It's clear and pale here. Others are more kind of small, dark, and cuboidal. So you kind of, and that's what kind of differentiation do you usually think of when you see that kind of combination?
I was thinking whenever I was looking at those eccrine.
Yeah, eccrine. Eccrine, or if you see decapitation secretion, apocrine, there may be a little bit of some of that in a couple of these areas, but good. So what was your diagnosis here?
Ecrine's hydradenoma.
Yeah, I like the hydradenoma idea a little bit better. It's kind of got, usually in the hydradenomas, most of the time it's kind of just pretty solid, and you don't see this many ductal areas here. So this is kind of a little bit of a hybrid, if you will. It's got some areas that look a bit like a tubular adenoma, and other areas it looks more like just garden variety hydradenoma. But it's totally benign, and it's got these clear cells here with some little cuboidal dark cells that are interspersed. So that's a really nice example.
So
What do these look like
if we
clinically?
call it tubular adenoma, would it be correct?
It wouldn't be totally wrong. We thought it was maybe a combination of both. So it's definitely got areas of hydradenoma. These things often don't read the textbook, so it's not that critical. It's mostly the ductal thing you call like a tubular adenoma. So these look like a cyst or a little pacule. Usually people don't even never make the diagnosis of these. Okay, so these are some other items in the differential diagnosis. So again, I think it's probably, some of the things in the bottom, hidradenoid papillifera, most generally have more papillomatosis to it and more villus frond-like changes. You don't really see that in this lesion here. Okay, so pretty straightforward lesion. Everybody get this one right?
Well, said it's spirit.
Spearhead and aspirinoma looks a little bit different. That's more blue, small cuboidal cells with small pinkish globules in between the individual cells. You usually don't get the nice ductal differentiation, the clear cells like this. So that looks different. And cylindroma don't look anything like this. So this is definitely a different morphology than you see with aspirinoma. Okay, this is a very nice example of this.
This is a punch biopsy, a little bit squares.
A little bit square?
Yeah.
Kind of a lot squared.
Yeah.
So when it's a lot squared like that, what do you think about?
Well, when you enter the sclerodermoid differential.
Well, there's dermal sclerosis,
Yeah.
probably. So you can see low power that's not
Yeah.
normal power.
Mm-hmm. There are areas of abnormal collagen, definitely.
Good.
There's this infiltrate that is from these power looks mixed, like lymphocytic and histiocytic.
Good. There's some pale cells
Yeah.
here, darker cells in the periphery. Some of those are going to be lymphocytes. What other cell might you see here?
Histiocytes.
Well, yeah, I got some histiocytes here, but what other cell other than lymphocytes commonly accompany sclerosing dermal change?
You can have plasma cells.
Good. Plasma cells. Excellent. So what's the general pattern here?
So the first thing that strikes is that it's not exactly completely palisaded, like around the necrotic collagen or necrobiotic collagen.
It's pretty palisaded though.
I was having some.
Yeah, it looks pretty good. I mean, it's trying
I
to
was-
form a
I
little
I was having some
fort
issues.
around the degenerated collagen there.
My first thought when I saw it, that was more like into the layered cake appearance, to me at least.
Yeah, I'd say it's kind of layer cake. You got histiocytes, but that layer cake, quote unquote, is a type of palisading.
Oh, okay. I didn't.
That's what
okay.
that is. It's a variant of palisaded granulomatous dermatitis.
So, with this one, my first thought was NLD.
Okay. Did you have a second or third thought too?
I had a second thought, and basically it was GA because of the amount of mucin that I noticed.
Let's take a look. Was there much mucin here on a scale of 1 to 10 or more degenerated collagen?
It was more degenerated collagen,
Yeah.
and
So
so
don't
basically,
let one small feature throw you off when everything else is screaming the correct diagnosis. So it's got the degenerated collagen, it's got the palisaded granulomas that is kind of layered throughout the entire dermis. It's got lymphocytes and it also has plasma cells, which you don't usually see in GA. See the plasma cells here?
Yeah.
So don't have a second or third thought in that. Now there are some things in the differential, so yeah, you should say, well, it might be GA, but I'm going to reject that because GA usually doesn't have degenerated collagen, it doesn't have plasma cells, and it usually doesn't extend as diffusely. It can, but not like this, dense diffuse with palisaded granulomatous dermatitis. What else might you think about?
well, if it was deeper, you could think like a rheumatoid nodule or.
Yeah, and that usually doesn't have multiple areas like
No.
this either, does it? That's like
Mhm.
a large, round,
Yeah.
deep, usually deep. You can be seen in the reticular dermis too. What's in the center of the palisade in that condition?
You can also see like dead collagen or like.
Can collagen die actually?
Well, not really, but it's something we miss. No, but
What do we, collagen's like a fiber.
Yeah.
So it's
It's
not
not
really
alive.
a live thing. So that's what I don't like about the term necrobiosis in a way. It sort of means death life, it's sort of
Yeah.
stupid. It doesn't make any sense. So basically what you're just getting is degenerated collagen. And do you see degenerated collagen in the center of the palisading rheumatoid nodule?
I think you can.
Not usually. What's usually in the center of that palisade?
Fibrin.
Yeah, fibrin. So that's what helps. If you get mostly mucin, it's more likely GA. Mostly degenerative collagen, it's more likely this, and mostly fibrin, it's more likely rheumatoid nodule. But you look at it in the context of everything else. So that's just, those are the three little pearls that are in the center of the palisade of those things. But this would never be rheumatoid nodule with this morphology. And there's one other thing that can look a lot, sort of like this. What if it has a bunch of neutrophils in it? The person's got lupus. Not tumid lupus. There's a palisaded granuloma stomatitis associated with connective tissue diseases, and usually has neutrophils, histocytes. It looks a little different than this pattern. So this is an LV, and just a couple of examples clinically of that, as you can see. Okay, so these are some of the other things, the differential diagnosis. Annually elastolytic giant cell granuloma. I personally think that's probably a variant of GA, so undamaged GA, but some people split that out as a different thing. Necrotic xanthogranuloma, that's another item of the differential diagnosis. That's associated with paraprotein. A lot more inflammation there. Cholesterol clefts, a lot denser and diffuse infiltrates. It doesn't look like this. Okay. So anyway, you guys got it right. Everybody remember this? What's one other item, go back, that's in the differential that they didn't put on here that's probably very important to at least know about, that can look like a palisaded granuloma, but it's not? You look at a higher magnification, you get degenerated, it looks like degenerated collagen, start looking, it's actually degenerated neoplasm. And it's got mitotic figures at the periphery. It's atypical. It's on the arm of a 30-year-old person. And it's thought to be maybe GA or something clinically. And then they pop up with lung metastases. Epithelioid sarcoma can look like a palisaded granulomatous dermatitis. You can simulate that. You have to at least remember that as positive staining vimentin and cytokeratin. Okay, here's a relationship with diabetes, so you all guys know that's related to it. Okay, let's let this one go.
So this one, so it's punch biopsy. Already kind of got low power here. It's neoplastic or malignant gene.
Okay, what
So-
kind of differentiation?
So I couldn't decide at first if it was either like lymphocytic or maybe melanocytic.
Okay, that's fair. When you went to higher magnification, what did you end up thinking?
So when I went to higher magnification, I still kind of stuck with the lymphocytic.
Good, good. Lymphocytes. Excellent. So no nesting, no junctional component, no melanin. So those would be things that, yeah, low magnification. So maybe it's a funny, melanocytic lesion. You just go higher magnification, you reject that.
Mm-hmm.
Good. So if it's lymphoid, is it more likely to be benign or malignant based on this?
Malignant.
Yeah. How come?
Well, it just looks pretty ugly. So the
I promise you that's not going to be a criterion they're going to ask you on the board. They're going to say, pretty ugly is a choice. C, pretty, oh, I check that one.
So the infiltrates is very irregular. It's infiltrative.
Yeah, it's asymmetrical, isn't it? And it goes deep. It almost seems like it's a little bit more bottom heavy than top heavy. It's kind of extending down pretty deep into the. Yeah, so it's kind of going deep. There may be a little necrosis here in this side. But it's lymphomas tend to be more bottom heavy, especially B-cell lymphomas, as opposed to top heavy, just as a general rule. Obviously, mycosis fungoides, that's an epidermotropic thing, so it looks a bit different. When you're dealing with a nodular lymphoid process, if it's deeper, favors malignant. What else, if this were going to be a pseudo malignancy, would kind of favor benign here?
It would go all the way to the epidermis.
Well, if it's a B-cell process, actually not. They tend to give you kind of a grin zone, so that it actually doesn't involve the epidermis. But if it's a benign pseudolymphoma, what's that going to look like? What kind of infiltrate's going to be in there?
Plasma cells?
You might get some plasma cells, but what other thing? What causes pseudolymphoma? nodular scabies, insect bites, those kind of things. So you're going to see, what are you going to see? Eos. You're going to see eosinophils. Basically, that's what's happening there is it's sort of recapitulating a little lymph node in the skin, so you get germinal centers. You see tingible body macrophages, so things, it looks like a reactive lymph node. Does this look like a reactive lymph node?
Mm-mm.
No, it doesn't. No germinal centers here.
Yeah.
A lot of these cells are pretty large.
Mm-hmm.
Now,
I was looking at a little, which is lymphocytic.
yeah, it is lymphocytic. Lymphoma,
Yeah,
right.
like a CLI. I kind of thought it was like a CLL. That's what I thought.
Well,
I don't think that's
CLL, generally, we do see that on occasion when it involves the skin secondarily. Usually, it's not this diffuse and dense. It's kind of like, it looks really almost like a lymphocytic infiltrate. So this would be a little funny for CLL involving the skin. But if you got into the malignant lymphoma category, that's really mostly all you need to know. They're not going to
That's as
ask
far as I
you.
got.
I ask you a lot of questions about, lymphoma pathology. That's out of the realm of what you need to know. But if you got it into the B-cell lymphoma category, that's good. So there's an ugly mitotic figure there.
Yeah, it was pretty ugly.
So this happens to be a marginal zone lymphoma. Okay, and these lymphomas tend to be a very good prognosis. 95, 100% 5-year survival. They often appear just as one or two little lesions like this. You can often treat them with steroids or size them, or you can try local radiation therapy. They usually do very well. They sometimes can be associated with other things, but most of the time they're very, very bland and they're not really that harmful to the patient. They often have some plasma cells. So the follicle center cell lymphoma doesn't really have a plasmacytoid morphology. These lesions often do have some plasma cells or plasmacytic morphology to some of the cells here. And if you do light chain restrictions, there's a plasma cell right there. If you do immunoproxy stains for immunoglobulins, they're often light chain restricted. So that's helpful. So this was a marginal zone lymphoma. But if you got into the lymphoma category, that's really all that matters here.
Okay, because I got to either follicle center or marginal, but I couldn't decide between the two. Is that
Yeah.
something we would have to just?
No.
Okay, we'd have
No.
to get some stains.
No, that's Dermpath,
Okay.
not derm. Okay, very good. Yeah, here's the immunohistochemistry if you just want to look at it. Okay. BCL2 positive. Okay. Who wants to do this one? This is a very, very excellent, fantastic case, by the way. I know you hate it when I say that. Should get it right.
Okay, so here's punch biopsy.
What part of the body?
The part of the body. And
And that's helpful in this case.
there's quite a few vessels up top.
What part of the body did you say?
I'm trying to. I know there's a lot of epidermal necrosis, so it's a little hard. Maybe acral skin.
Acral,
Okay.
yes. Notice it doesn't have any follicles here. It's got a markedly thickened cornified layer, and it does have a lot of epidermal necrosis.
Mm-hmm.
Now, what conditions give you epidermal necrosis on acral skin?
Conditions that maybe involve the vasculitis.
Yeah, because the blood vessels are small there, aren't they?
Mm-hmm.
So if something happens and they get choked off and they can't provide blood to the tips of the fingers or the tips of the toes, the skin gets necrotic.
Mm-hmm.
So just by looking at that, it gives you a clue as to what you might be dealing with. So what's the pattern here?
Vasculitis.
Vasculitis. Okay, so there's several different types of vasculitis, aren't there?
Mm-hmm.
Okay, what are the main subtypes of
There's
vasculitis?
Small vessel vasculitis.
Yeah, and that's one of the problems of vasculitis is there's several different ways of classifying it. You can
Right, there's many
anatomic,
different
you
ones.
can have physiologic, pathophysiologic. So let's use the pathophysiologic histologic rather than the size of the blood vessel in this case.
Well, then there's neutrophilic, I guess, would be
Well, or
small
what's the
vessel.
one where you see it can be small or large blood vessels
Granulomatous?
involved? You can get granulomatous vasculitis. That's true. What else can you see histologically that's more of a related to the type of infiltrate?
I mean, you can see Cardiorexis with
So
small
that,
vessel
so what do you
vasculitis.
call that? If there's
Vas-
Cardiorexis, what's that called?
Small vessel vasculitis and with fibrin deposition.
And what's that called? What's another name for that? You're saying it, you just haven't put the word to it.
Leukocytoclastic
Leukocytoclastic vasculitis, LCV.
There's so many names.
So that's another one. So what's another? What's another type? What if you don't see much inflammation at all? Lots of thrombi within the vessels. What's that called?
Vasculopathy.
Yeah, thrombotic vasculopathy.
Mhm.
Okay, so there's a couple others. We haven't made the diagnosis yet here.
Well, there's that, which is a medium vessel as related to the skin at least.
Okay, is this normal?
That is not normal.
What's going on here?
It's the vessel is being destroyed.
How is it being
I
destroyed?
think it's necrotic, but I'm trying to
Well,
see
actually,
what the process.
I don't know that it is necrotic yet. There's one inflammatory cell in the wall.
Mm.
That the wall may be undergoing incipient degeneration. I
Mhm.
agree with that. But this part's still pretty healthy out here. But what is actually happening right here?
A thrombus?
Yes, a thrombus is being thrombosed, and notice it's got some fibrin in here, but it's also got inflammatory cells.
Mhm.
And what are these inflammatory cells?
They are lymphocytes.
A few lymphocytes, but that's a neutrophil right there.
Okay.
So there's neutrophils, maybe a few histiocytes and lymphocytes, but there's neutrophils.
It's mixed.
It's like a clot.
Mhm.
Yeah, it's got red cells. So this blood vessel is clotted off, but it's got inflammatory cells. So it's not a thrombotic vasculopathy, right?
No.
So it's got inflammatory cells. It doesn't have leukocytoclasia.
Yeah.
Not much.
Yeah, it's
Very, very little, if any. Mostly intact neutrophils,
Mhm.
lymphocytes, not a lot of leukocytoclasia. So you've got vascular thrombosis with red cells and inflammatory cells and intact neutrophils. What's that diagnosis?
polyarteritis.
No,
No.
because that's leukocytoclastic vasculitis.
Mm.
So it's causing epidermal necrosis because it's causing ischemic necrosis of the overlying epidermis. It's on the acral skin. Patient's probably got fever, it might be sick, they might be in the ICU, or they could be walking around. No, purpura fulminans is DIC, that's thrombotic vasculopathy,
Yeah.
so it isn't that.
So that wouldn't have all the inflammation that we're seeing.
So we got intact neutrophils
Yeah.
and blood vessels that are thrombosed with inflammatory cells in the vascular thrombus.
Okay.
So what's that diagnosis?
Something infectious.
Yes, so what's that called?
Septic vasculitis.
Septic vasculitis. That's the other major category of vasculitis that we see. So that's what you see with septic, those criteria that I just said. So limited leukocytoclasia, if any, because it's not an immune complex mediated process, right? This is due to circulating bacteria that cause this process, or circulating yeast, or whatever the organism is that the patient's got. So it's different pathophysiology than an immune complex mediated process like vasculitis of lupus or something like that. And it gets lots of blood vessels, so they get like overlying epidermal necrosis and an infarct. So this is kind of what these things look like. Look at that hand on that kid. Look at the fingers and stuff. So this is very characteristic when you see those kind of things in septic vasculitis. Okay, so these are some of the other types of vasculitis. But if you remember this sort of 2 + 2 = 4 sort of thing, you know, fibrin thrombi plus leukocytoclasia, that's LCV, immune complex mediated, lots of thrombi, no inflammation, that's vasculopathy. This pattern, we get intact inflammatory cells, vascular thrombosis, usually some of the larger blood vessels involved, that's more likely to be septic. You can get a lot of stasis change with lots of fibrin in the blood vessels with variable amounts of inflammation, that's lipidovasculitis. So you can apply these criteria and get diagnoses made pretty well. You can use these criteria. Okay, so these are some of the other subtypes. You know, gonococcal lesions commonly give you pustules over the joints. You see that. And meningococcus, pseudomonas is bad if you get like that's often fatal. It's really a bad situation. I'm a gangrenosum. Okay. All right. So we'll go to the next one here.
Okay, so this is a shave biopsy
Okay.
of acral skin. The dermis isn't very well visualized in these specimens, but it looks like there is a little bit of acanthosis. When I was studying them at home, I didn't find too much inflammation,
Good.
but I felt that there was something to be seen in the stratum corneum.
Okay. What was there to be seen in the stratum?
So they were little non-human entities.
Oh, I'll buy that.
They look like they were possibly some little.
We need to switch over to the pathology part when we do this. Toggle back and forth. Where's Brad? I don't think the people online can see this, can they? Yeah, I think you have to switch over. I thought the image, this image goes up here. Okay.
Yeah, so you can see them better on higher power, I think, but it looks like they were some little hyphae.
I think it's just a toggle. Hyphae.
Mm-hmm.
Okay, anything specific about these hyphae? There you go.
They're in stratum corneum. Their color kind of a purplish color. They didn't seem to be.
Is that purple?
I don't
I
know.
don't know.
Is it brown?
It's brown. Yes, brown. What causes that brown color in those hyphae?
What causes it? Well, it's due to the species or the category of tinea.
Yeah.
But I don't know what exactly.
I think it's actually melanin that causes that
Oh, it's
color.
melanin. Okay.
Pretty sure it's melanin, just like it is brown in the skin of humans, I think. But yeah, so this is what do you call this type of fungus?
Tinea nigra.
Yeah, it's tinea nigra is the diagnosis, and this is dermatiaceous fungal infection. What are the potential organisms that cause this?
Reinecke is the main one.
Yeah.
Um,
What's the genus and species now that we've
Oh.
changed it? Let's switch over now to the other. So we had to switch back and forth. So that
Hortae, yeah.
Yeah, Hortae wernickeii. It used to be called Cladosporium wernickeii. What do you think they thought this was clinically?
maybe this thing.
They usually make a diet. They think it's melanoma.
Oh,
You get
there.
these, submitted as rule out melanoma fairly frequently. So it's now called Hortae wernickeii. And there are other dermatiaceous fungi that you should know at least. Fonsecaia, that's another one. Phylophora, those are things that can cause other types of dermatiaceous fungal infections. Exophyla, Johnsellmi. So just make sure you at least know a little bit about those. But this was tinea nigra this time. It's pretty straightforward. So usually it's a slow growing thing, and it usually gets sent in as rule out a melanocytic lesion. Okay. All right.
Alright, so I have a shave of a little papule that also looks like it's on volar skin.
Okay.
So I think the action, I guess, is in dermis. There's not really didn't see a whole lot going on in the stratum corneum.
Yeah, it's mostly a dermal-based process.
Some little vessels you can see from here, not a lot of inflammation.
Yeah, no inflammation.
Yeah.
So did you think it was an inflammatory or a neoplastic process?
I guess neoplastic.
Yeah.
Yeah.
I mean, we talk about neoplasms, we kind of lump hamartomas into that sometimes. And what kind of differentiation did you think this was exhibiting?
It was like fibroblastic, like collagen.
Yeah, good. A lot of fibroblasts in here. A lot of collagen. What else?
Those vessels.
A lot of blood vessels. And let's take a look at some of these fibroblasts. Some of them are kind of large and pleomorphic and stellate. Is it like a variant of a sarcoma that's developing here, or?
I don't think so. I think it's just maybe like a reactive process or just growing, I guess.
Yeah, or it's not uncommon to see stellate fibroblast in this specific lesion. So what's the diagnosis here?
So fibroblastic process on volar skin, think of like acquired digital fibrokeratomas.
You could, although those usually don't have quite as much
That's it.
vascularity to it, and they don't usually have as many of these stellate fibroblasts.
I didn't see any like nerves or anything to make you think of like a supernumerary digit,
Good, I agree. I don't think it's that either.
or like the other thing I think of was like if there's vellus hairs could be accessory tragus, but
Yeah, none of that. I agree. It doesn't really fit for that. So what did you come up with a diagnosis here?
I thought it was acquired digital fibrokeratoma.
Well,
or
it's
just
close.
or just a collagenoma.
What if, well, it's on the acral skin, which would be a really
Yeah.
bizarre location for that. It does look like a papule. What if I told you this guy had about 4 or 5 of these coming out of his proximal nail fold? And also
like-
maybe,
Like a Conan's tumor.
yeah, Kenan tumor. I don't know, I'm not a German, I can't pronounce it very well, but, yeah, so what is a Kenan tumor?
Yeah, so then these are angiokeratoma.
Angiofibroma, right? Angiofibroma, which is the same kind of thing you see in the face, and adenoma sebaceum. So we'll take a look at the clinical here on this. Okay. So yeah, these little cloves of garlic right there. So this is basically pathognomonic of what?
Yes.
Yeah, tuberous sclerosis. And we know what the gene is associated with that, right?
Hamilton.
What was that again?
Hamilton.
Is it Hamilton or Tuber?
Tuber.
Yeah, Tuber. It's one of the few they made a good name for. So you can remember it. So yeah, these are the other things with the differential diagnosis. But these really look like angiofibromas. So basically, just understand that some people think they're variants of fibrokeratomas, but usually they're really not the same. They're usually a little bit different than that. I think they look more like an angiofibroma than a particle fibrokeratoma. If you got it in that category, you're probably okay. But it's usually associated with TS. Okay. All right, we have a fungal culture this time. How about that? Guys see that every day?
Well, that's how far I got. It looked like a nail clipping to me, and then I could see that there are a lot of hyphae.
What stain is this?
Is it PAS?
Yeah, this is a PAS stain. So here's the nail plate. So this was actually a fungal culture that they grew, and then we took it out of the nail and the auger and looked at it under the microscope.
It looks really purple.
So these are little hyphae. Okay, you start looking at them, and the board doesn't ask too terribly much mycology anymore, but they might ask a couple of questions about it. So what general genus do you think we're looking at here? Yeah, Trichophyton. Trichophyton. Now they call it Trichophyton, meaning it really loves the hair, Trichophyton, but we also know that it loves the nails also. So there's two main Trichophyton species that give you nail fungal infections. What are those?
You know, rubrum is one of them.
Rubrum is one. What's the other one?
Mentag.
Mentag. Mentag. Now, mentag means painful chin. So that's often, usually it'll involve the face too, but this, the glabrous skin, but it also likes the nails too. So this was, in this case, T. mentagophytes. There actually are some little small macroconidia. Usually don't see very many of those with the Trichophyton group, but there were a few of those here. There's some terminal chlamydospores here. So I think we got a picture of what this looks like on culture. So here's the nail, obviously, basically just subungual. If you're going to culture this, you really should try to get some of that white, chalky material, and it does best if you get as proximal as possible. If you just get distal and clip it and stick it in, it may not grow. It may have they may have an infection, but it may not grow, and you may not even see the organisms. So the organisms can be like very sick. They're not normal fungi when they're sitting in your nails, so they may not actually grow very well. So these are some other. This was T. mentagrophytes causing onychomycosis here. Okay, so the rubrum, mentag, you can see the organisms there. Do you have pictures of, yes, of the photos here? Yeah. So T. rubrum, you get these little small club-shaped, teardrop-shaped microconidia, and if you do get macroconidia, they're kind of like that little 4 to 10 cell long thing up in the upper right-hand column. And mentag, they're similar. They look a little bit different, but they look kind of like that. You get those little spiral hyphae. I don't remember, did we have any of those in here? I think we might have actually found a couple in this. Kind of interesting. So again, I don't think you're going to be called upon to know a ton about mycology, but at least you should have some familiarity with it. And you obviously know this is not microsporic. Those look like football macroponidia, and they have a lot of those, not like these long sort of clavate, piriform club-shaped macroponidia. And then yeast, these are some examples of that. So yeasts are round, and you get these germ tubes. So these aren't really truly hyphae. They're little sort of germ tubes that just come out of the yeast, and they tend to grow in right angles into the skin. They don't usually cause true onychomycosis. They usually cause paronychia. Rarely they can cause nail infection, but they usually don't. Okay. Back to more routine dermatopathology. So who wants to give this one a go? That's a good example of this too.
So this is shave biopsy, and there are a couple of things that are striking. Looks like it's ulcerated and like an ulcerated papule, and the other striking thing is clearly there's a dermal process with clear cells.
Okay, we've already had one clear cell process today. Now we got a second one.
Yeah. So, and the other striking thing is how vascular it is among the clear cells.
Okay. Does that bring anything to mind?
Yeah, the first thing like we're trained to think of when you see clear cells with a lot of vascular spaces is renal cell carcinoma.
Good.
That's the first thing.
What's the second thing?
So I'm not sure if there are many others that can look alike, but maybe other metastatic processes.
But not too many that really have all this vascularity and the clear staining cells like you see here. So you're exactly right. This is an example of metastatic renal cell carcinoma. And some of these are kind of beginning to try to form little nephrons like right there. You see that? It's trying to form a little nephron. So that's very helpful. So this is metastatic renal cell carcinoma. A lot of times the cytology of these is relatively bland. You don't really see a lot of mitotic figures. So a lot of these patients actually do paradoxically better with their metastatic disease than you would think. There's a mitotic figure there. But anyway, so this was renal cell carcinoma. And these will stain positively with the RCC stain. They're often, next slide, they're kind of bluish like that, and they can pulsate in some cases. So you want to just make sure that you recognize this entity. I've seen them misdiagnosed as pyogenic granuloma. They also will stain positive for some of the other markers, CEA, EMA, and CD10 if you need to work them up. Okay, next. Okay.
So, looking at this, so these two slides were like the two samples were a little different looking to me, I think. Yeah.
Probably did a big giant sort of incisional, maybe even try to kind of drain this thing. You know. So what's the pattern?
So it was infiltrate or inflammatory.
Yeah.
So
Inflammatory?
inflammatory pattern
And then what's the overall pattern?
is like
Everything's involved, isn't it?
yeah.
What do we call that? Just whenever it's just very, very diffuse and dense, we call that what? dense diffuse. And what kind of cells are in here? Neutrophils, tons of polys. And there's some histiocytes. You've got these pseudoepitheliomatous hyperplasia lesions here that are probably little sinus tracts. Okay, so you got a suppurative and granulomatous dermatitis. What kind of things do you think about here?
So I think of HS first.
Yeah, you think of anything that can give you like a suppurative granulomatous process infection. In this case, it happened to be hidradenitis suppurativa, but you can also see similar patterns in acne-Q-analis nuki. You maybe want to rule out other kind of infections like sporo and things of that nature. So this happened to be hidradenitis.
So
I looked for bugs here for like hours.
Good.
And couldn't find anything.
and my
What?
final answer was like some sort of folliculitis or something.
Yeah, that actinic keratosis nucleus. Whenever I was looking
So
at it.
so how would you? There's no way to differentiate
No, and you don't,
AKN
and you
or-
don't need to,
Okay.
because they're all part of the same spectrum.
Okay.
So you don't need to differentiate. If you just get this in the category of suppurative granulomatous dermatitis, rule out infection, and this is an infection.
Yeah.
It's an infection due to bacteria and clogged pores and all sorts of things like that. So basically, it is a type of
Because
infection.
the photos in the book for both of those look identical.
It's the same
So I
thing.
couldn't.
I switch over to the clinical.
And dissecting cellulitis and all-
Same thing.
Okay, good.
It's all the same spectrum of disease. As long as you're aware of that, we can show you the clinical photos. You all know what they look like. But the key is other things in the differential, other infectious diseases. So,
Mhm.
okay. All right. Anything else? Next. So, you all guys know what this looks like. Suppurative granulomatous. Okay. All right. Who wants to do this one?
I do.
This is a great one.
All right, so here we have a shaved biopsy, and the skin is the epidermis is a little papillomatous.
Okay.
But what stands out is acantholysis.
Good. So, what's the pattern?
I think I didn't see a whole lot of disc keratosis.
Right. So what do we call it?
Acantholysis.
Intraepidermal acantholytic vesicular dermatitis.
Yes.
Okay, so what's the differential diagnosis of that pattern?
So, pemphigus.
Yes.
Differential HSV. Something to think
Yeah,
about.
it could. Yes, it can do that. What's this phenomenon we're showing right here?
In the hair follicle, it's extending down into the hair
Yeah,
follicle.
it's tracking into the hair follicle.
Mhm.
So that favors real
Real. Yeah.
as opposed to like Grover's
There
disease.
was a really funny part of biopsy that looked a lot like viral
Do
cheese.
they need to switch it over to the? Are we good?
But yeah, the follicle definitely turned me away from viral.
So yeah, so this is an example of pemphigus vulgaris.
Mhm.
Excellent. And if you did immunofluorescence, you're going to see immunodeposition of IgG and C3 intercellularly here. What's pemphigus vegetans? Switch over to clinical.
Pemphigus vegetans will have more eosinophils. They can have more eosinophils. Eosinophilic abscesses. It's more acanthodic.
Yeah, it gives you
It's
marked. It
vegetative
really
lesions.
looks almost verrucous.
Mhm.
It's usually it's variant of pemphigus vulgaris occurring in intertriginous areas, and it's really verrucous and whatnot. And you may not even see the actual acantholysis. Sometimes it's really difficult. Obviously, it's not superficial pemphigus. This is really deep and suprabasilar. Okay. All right, and this is desmoglein. Okay, so they are going to ask you that, of course. Okay. Got 2 more.
So this is a shaved biopsy, non-acral skin.
Could it actually be acral skin?
Maybe.
It'd be kind of close to it. I mean, it does have a thick granular layer and lamina lucida and no follicles. It's a shaved biopsy, but
Yes. And sorry, I'm just making sure. This is 105, right? Oh, 104? Okay. Sorry, I was looking at the wrong one. So I thought that there was a lot of vacuolar change in this one.
so vacuolar change? What's the actual pathophysiologic process going on inside these keratinocytes here?
It doesn't look like it's dyskeratosis exactly.
Well, there is some that they're dying here,
Okay.
but they're filled with liquid.
Mm-hmm.
They're pale.
Yeah.
So what do we call that process when they're sort of puffed up, filled with liquid?
Yeah. Ballooning.
Ballooning
Yeah.
generation. Good. So
Um,
what is that? What category does that put it into?
So that makes me think about viral change.
Could be viral.
Mhm.
What else can give you ballooning?
I'm not sure than viral.
Well, sometimes if you apply sort of an irritant to the skin, you can get balloon
Oh,
degeneration.
like cantharidin.
So yeah, this guy probably, I think he immersed his hands in gasoline or something like that, or maybe they applied some kind of product to try to get something out of his skin. So what is the diagnosis if he did that then?
Like a burn.
Well, a chemical irritant or an irritant dermatitis, irritant contact. So if you biopsy somebody that's put an irritant on their skin, maybe they put soap on their skin or
Yeah.
something like that, this is what it looks like.
Oh.
Okay, it does have a lot of these cells are all dying kind of over a diffuse front. There's really no viral cytopathic effect of the cells. So
Yeah.
this is an example of irritant contact. So I'll show you what that looks like. So this is not allergic contact dermatitis because there's no spongiosis here. This is more of different patterns of toxic reaction. So this is a different pattern all the way. So irritant contact dermatitis, and those are the items that are different for diagnosis clinically. Okay, so ballooning. Remember ballooning plus epidermal over a broad front, think irritant dermatitis. Okay, the last one. I want to give this one a go.
Very thin shave.
This was a very good example of this.
It's thin shave and maybe easier on some other cuts to see, but there were some nests of melanocytes at the DJ.
So we're sure they're
I
melanocytes?
saw. Say that, but probably not. Nests of cells.
Okay. But it does show the pagetoid pattern, right?
Mhm. Yeah, there's dermatopathology, or yeah, pagetoid spread.
Okay. So yeah, the melanocytes is one thing that could do that. What have we got here? Does that look like a nest of melanocytes?
Really kind of weirdly shaped.
Yeah, it looks almost like a little gland.
Yeah.
And that also is like a little lumen right there. So now what do you think about?
So now I'm thinking of like glandular, like adenocarcinoma.
Yeah, what do you call that?
So then that would be like just pageants.
Yeah, pageants. So it could either be mammary or extramammary pageants. Either one can give you the same pattern. We don't know that. But generally, if you see that, I mean, it's like a slam dunk. You know that's what it is. If you don't see that, usually these cells are not usually just exactly at the basal cell layer. They're usually kind of slightly above it, commonly. And it's not like you don't really see the same kind of nest you see with the melanocytes. These have more cytoplasm in them. If you were to stain this, it's positive for CEA and CK7.
So to differentiate,
Photograph.
like you were saying, between just pageants and then like melanocytes, do they have more like clefting? It seems like some of those have like bigger, or maybe just
The cells, you see intercellular bridges between these. They have more cytoplasm. If you're not sure, you can always stain it. But generally, if you see any kind of glandular differentiation, you would think of this being extramammary or mammary pageants disease, like you have over here. And you don't get full thickness atypia throughout the thing like you can see in pagetoid Bowens, for example. So that you don't see that because this is colonizing the epidermis. It shouldn't be there. It's not the epidermis itself is neoplastic. And this is what these things often look like. They're red, they don't heal, they're often misdiagnosed, they're often thought to be, next slide. You can change the slide here. So they're thought to be like inflammatory, so these things get misdiagnosed as candida or things like that, so it's often a late diagnosis. Langerhans cell histiocytosis can look like this too. Okay. So pale cytoplasm, may see glandular area. You need to look for an internal malignancy if it's in the breast